I'll start.
Yeah, please start.
Yeah, good morning, everyone. I welcome you to this session on uterine artery at origin. So this is, in fact, after we received the feedbacks from many people that we have request that we should cover laparoscopy topics also. So this is one such topic which has been requested, and we start one topic week on endoscopy. So this is the first one. So I'll hand it over to Dr. Jay to take it forward. So I request everyone, whoever has not given the feedback, to kindly take some time out and give the feedback so that it helps us do better in choosing the topics and also to, I think, refine our content. Yeah. Over to you.
Okay. So basically, I will just start with my screen sharing and screen is visible, no, Shilpa madam?
Yes.
Okay. So I have gone on to YouTube, and if you just search uterine at origin, okay, see the first two videos, okay, are going to be our videos because they have become quite famous. Okay, as far as this is concerned. Okay, so I will go to this one, which I think is a slightly better video, and I'll try and go full screen uh, on this. Shilpa madam, this thing is audible, right? What I'm trying to speak,
Yeah, what you're speaking is audible.
what I'm speaking is audible, right? Okay, fine. So again, very important to understand that whenever we are talking of uterine artery at origin, can you hear this? The video, what is playing?
No.
Okay, fine. See, why do we need to do uterine at origin? That is the first question. Do we need to do it in all the cases? The answer to that is a straightforward no. Okay, so that is your first take home point for this masterclass. You don't have to do uterine at origin in all the cases. That is the first. Second, please understand as we go through this video, after the end of this video, I'm going to draw an embryology diagram. Okay, that will clear off all mistakes which you have in your head as far as uterine is concerned. Okay, so let's assume whenever you want to do a uterine at origin. Okay, so you can see here. Is the video clear, Shilpa madam?
Yes, yes.
Okay, see this. Lift the IP ligament and just open the peritoneum lateral to it. See that automatically the peritoneum gets open up. Now, once you go deep, okay, this is important. See, I'll just pause it here. Okay. See, this is what is important for people to take home in their head. Okay. Very important. Okay. So I will just ensure that this is a point which is driven home. You must open the peritoneum between the round ligament and the IP ligament, irrespective of open surgery or laparoscopic surgery. If you standardize this as your approach, always remember what we are doing here. We are pulling the IP ligament towards the midline and towards the anterior abdominal wall. So you pull it in the cranial direction and the medial direction. Very simple. Craniomedial traction to the IP ligament. What this does is it automatically allows you to identify the ureter and the uterine artery both in the same plane. Okay, see that. Can you see what is that structure there? That structure down, right? That's the ureter. Okay,
It's a little
that is
blurred.
it.
I mean, have you reduced the speed or something?
No, my speed is just the same.
Okay.
Is it very blurred?
It's a little. Uh,
I'm playing it on HD, high quality.
okay.
Shall I reduce the optimization? Wait, I've played it on auto mode now. Now you will see it better. See,
Yeah, this is better. Much better.
yeah. Okay, fine. So see, this is important, guys. Just divergent forces of traction and open. It is, this is a live video, as you see, and the live video is also as simple as it is. Can you see that? Just use divergent traction. Finished. Saw that? Very gently, just open up everything. Okay, another important thing, so I'll pause here. See, it is important for people to understand no matter what instrument you want to use. Okay, no matter what instrument you like to use. You can use an instrument which you love the most. It doesn't really matter. As long as you are doing it in the correct plane, the bleeding is going to be micro minimal in this surgery. And as long as you are hitting on the correct structure, you don't really have to worry about anything else. These are the two other take home points of this procedure. Okay. So there you go. We grasp the uterine. Okay. And we will simply coagulate. Now you can coagulate. You can clip. See that? Push the ureter away. Okay. Everything is in the center and just coagulate. Okay. Honestly, this is all that you need to understand and learn as a part of this entire procedure. But before I stop the screen sharing, okay, I also want to go and show a diagram of this because many times people have this huge confusion, okay, as to why is it like this? Why do we have to go to the uterine and what is going to happen to the ureter and all these things? So kindly understand, surgery is a game of anatomy and embryology. Okay, if you understand the anatomy and embryology correctly, you don't really have to think much about it. Okay, so when the fetus is developing, no, from the cloacal membrane, okay, which is at the caudal part, you are going to develop bladder, lower one third of ureter, okay, lower one third of vagina. Okay, these three things you are going to develop, and of course the anal orifice. Okay, these things are going to develop from the cloacal bud. Okay, up somewhere up posteriorly you have two people who are trying to descend downwards. One is the mesonephric duct, other is the paramesonephric duct. Okay, so this, let's assume this is the paramesonephric duct. The paramesonephric duct wants to descend downwards towards here. Okay, and a part of this wants to go upwards. Okay, so embryologically these two guys are completely separate components. Please understand this, as a result of which you will have predominantly the ureter which goes and gets adherent to the peritoneum. Okay, that junction of the ureter goes and gets adherent to the peritoneum. So the minute you pull the peritoneum in any direction, okay, the ureter gets pulled along with it because the ureteral adventitia, even embryologically, is adherent to the peritoneum. Okay, and one more very important thing which you must note, which you must understand is embryologically also this structure, which is the Mullerian bud, which is going to develop into your uh, which is going to develop inside the uterus. I mean, which is going to develop into the uterus. Okay, see, this not just moves down. If you see, it moves down and it moves in the front. Okay, it moves down and it moves in the front. As a result of which, embryologically, what will happen is, if you try and understand in 3D, it is not just coming down. It is coming down and going here. Okay, so that it has to come to the midline. Now because this guy wants to come to the midline, okay, that is one of the reasons, okay, that is one of the reasons why you have a uterine artery which is tortuous. And second, uterus is a reproductive organ. In the reproductive organ, this tortuosity is supposed to become ideally very straight and very large when somebody becomes pregnant, as a result of which this is the one of the few arteries in the world which has tortuosity. So it makes it very easy to identify. And because embryologically it moves like this, it moves towards the midline, you must remember it bypasses the ureter. So don't eat that theory up that water is above the bridge or below the bridge or above the bridge or below the bridge. Just follow one standard dictum. Ureter is not going to go anywhere. Ureter has to go behind. Uterine artery embryologically also has to come in the front. So almost always, irrespective of the anatomy, your uterine artery is going to be above, no matter what happens to earth, okay, and the ureter is going to be below it. Okay, so when you coagulate it here, this is where the origin is. Your ureter is going to be little far off from that origin. In order to make it more safe, you are putting traction and pulling the ureter in the opposite direction and grasping the uterine here. Okay, and you are coagulating it. Okay, this is the embryological perspective of it, and people must remember, because I've seen a lot of students who come to us and ask us the same question, that why the uterine goes above the ureter and why the ureter goes behind the uterine. It's an embryological answer, so you need not worry about it. Okay, and finally, before I conclude this short session, just remember this thing. If you want to master uterine at origin, start doing uterine at origin in very benign cases. Okay, very simple cases, you should start doing it where anatomy is not altered. Okay, because the anatomy is not altered in simple cases, you will be able to easily find it. So that in difficult cases, your uterine at origin access is easy. Now, I will tell you predominantly in which cases you will need it. Whenever there is a bleeding at the vault, after hysterectomy, when the vault bleeder is there, which has not been coagulated properly, normally people go and coagulate the vault. Okay, instead of that, if you end up going and coagulating the uterine, the vault bleeding will also stop, and your low fistulas will also not be present. Your low ureteric fistulas will also not occur. Okay, there is a huge debate whether to do, any form of ligation at uterine at origin in cases of myomectomies, okay, or adenomyomectomies. And people will say that there is the highest level of evidence which states that if you coagulate, cut, clip, okay, it will affect the future pregnancy outcomes. This is one point of view, but please remember, in a routine practice, if you coagulate, you are doing internal iliac ligation in pregnancy, you are doing uterine ligation in pregnancy, and all these people, once the uterus resolves, they also become pregnant in the future. Okay, but just in case you are very worried, you can just do a temporary clipping. Temporary clipping is just done by our standard vasoclips. The minute you apply the vasoclip, okay, it's temporarily clipped, and you can just pull the vasoclip out at the end of your surgery. Okay, so with this, I finished this very short session. I really encourage everybody to go onto Facebook and watch this video, because we have shown it umpteen number of occasions. And you must start developing this as a part of your practice, because in difficult situations, when you want to access the uterine, I have shown what is a standard approach. But remember, if you remove the peritoneum from everywhere, you can approach the uterine from all the positions. Okay, just keep that in your mind. I will answer 2 or 3 questions and then we can conclude.
Yeah. So, in continuation with whatever video you just showed, I think you showed only on the right side. So the left side, I mean, there is sigmoid,
Same.
which is having the.
Yeah, just mobilize the sigmoid. In fact, I can play the left side. I just thought it's the repetition, so I did not play it.
Okay.
But in the left side, just mobilize the sigmoid first, and once you mobilize the sigmoid, go to the uterine. It's the same step.
Yes. So the first structure that you identify when you open the retroperitoneum is external iliac vessels. Okay. So
Yeah.
The dissection, I think, I mean, you have mentioned in your voiceover in the same video that the dissection has to be between the ureter and the external iliac vein. So this, I mean, identification of this external iliac vein sometimes becomes difficult because it is covered with fibrous tissue, fat. Yeah. So how do you tell the youngsters, or even I mean, people who are starting to do new?
Yeah, it is really absolutely simple anatomy. Let me just go to that video again and show it to you. Wait. Okay. It is really, I mean, it is real simple anatomy, but let's just have a look at it. Okay. See, this is the left side. Okay. I will just play the left side because the right side is already finished here. Okay. I'll just play the left side, just what you asked. Okay. Shilpa madam, just see this.
Yeah.
That's your sigmoid. Can you see that? Mobilize the sigmoid. Once the sigmoid is mobilized, can you see peritoneum opens up on its own? Can you see that?
Yes.
Okay. Now, when you lift the peritoneum, okay, just lift it. See that? That's the external iliac vein.
Yeah.
Just there. And that's the ureter below it. So it's so simple. You must always ensure, I again repeat, you must always ensure that once you open the peritoneum up, okay, once your peritoneum is opened up, Okay, that's the structure. There is actually no other structure there. See this.
Mm.
Can you see that? External iliac artery, external iliac vein. Simple. And give traction in the medial direction. Very simple. This entire fibrofatty planes will just open up. There is no adhesion there. The only case where there is adhesion in this entire situation, honestly, is when you have endometriosis there. Okay, absolutely nothing.
Okay, yeah. So I have seen you do it mostly for large uterus and myomectomies, and
Yeah,
also
yeah,
difficult endometriosis, which might bleed, especially in.
yeah.
Huh. So, do you do this even in the abdominal cerclages laparoscopically in pregnancy?
No, no, no. You are not supposed to coagulate the uterine at origin in cerclage in pregnancy. I
Yeah.
mean,
No, there was a
you will end
question.
up doing
Yeah.
you will end up doing laparoscopic MTP.
No, there was a question, so I just. So this retroperitoneal approach is posterior approach. And what about cutting and opening from the round ligament onwards? I mean, we get more space, we get more dissection, the clarity may be better. So what is your take
You are
on?
absolutely right. But once you go below the round ligament, the tortuosity of the uterus, I mean the tortuosity of the artery, okay, is much higher there. The first segment which comes out from the internal iliac is a flat segment. Okay. So it is better to open up in the center so that when you reach the flat segment of the uterine, you go and coagulate there. What typically happens is when you go down from there, you will reach the tortuous uterine, you will have to backtrace it. Okay, and when you backtrace it, you will have to coagulate. So better option is this, is what I think. But yes, that is an option.
Okay, and which one? Like, I mean, I see that yours is like very quick. Like you do it now within a minute. Though the video which you have played, I think it was 7 minutes. So that time it was 3 minutes probably for one side. Now it is a minute. So posterior approach, I mean, you think is quicker because you have standardized the steps, or nothing to do with the
No,
time.
no. It has got nothing to do with the time. Most of these videos put up are for demonstration purposes so that every point gets explained. You know, why, what has to be done. All right. If you do it in routine practice, after you do 20 cases or in benign gynecology, okay, you will end up coagulating and clipping the uterines much faster because you will get your own feel where the uterines are. Okay. You don't really have to worry about it.
So you do it with your sharer. So
Yeah,
do
I
you?
do it with the sharer.
Yeah. Do you encourage everyone to do it with the regular bipolar, or I mean, whatever instrument they are comfortable with, like harmonic or ligash or whatever?
Use any instrument of your choice. Okay. It doesn't really matter as long as you have skeletonized the vasculature, it doesn't matter. Okay. The importance is skeletonizing the vasculature, not the instrument.
Okay. So do you trace the ureter till the tunnel when do you encourage that?
Not at all. Not at all.
Uh, okay. And so, what about the superficial uterine vein? I mean, do we come across that sometimes when
Just
we
below the uterine. Sometimes what will happen is it is just below the uterine. Okay,
are?
just below the uterine artery. But it is a large segment of the vein which is merging into internal iliac vein. So if in case you are there, just clip it or coagulate it. Nothing will happen to it.
So what is your opinion on the shoelace ligatures, which is temporary, and then we can remove it post
It's very good.
procedure?
Yeah. It's anything which is temporary is good only. Okay, you can use shoelace, this lace, that lace, whatever you want to use. You can use clip, you can use whatever. Okay, it doesn't matter.
Okay, so the uterine artery separates the paravesical and the pararectal space, isn't it? So you generally just for the uterine artery ligation at origin, do you recommend dissecting both the spaces, or it's not required?
Not at all needed.
And what about inferior gluteal artery? If we come across just how do we identify? It is only with the tortuosity, the color, which is a little different in the uterine artery. I mean, is that the only thing?
No, one of the things about uterine artery is it is one of the only artery which goes in the medial direction, as I mentioned, because the uterus is centralized. That is why this is one of the only vasculature which comes from internal iliac which goes medially. Okay. Rest everybody enters in the pelvis or exits the pelvis. Okay. Everybody enters the pelvis or exits the pelvis. So all the other vasculature is going to dip down. This is the only vasculature which is going to go up. Okay. This is the only vasculature which is going to go medial. So just keep that in mind.
Okay, so between ligation at the origin and our traditional close to the uterus, so in which of these situations the ureter is susceptible for damages or the energy source, especially if there it is a normal anatomy?
For people who don't dissect the posterior leaf of broad ligament, okay, you will have a problem because you are ensuring that the ureter stays close to the uterus. As a result of which, irrespective of the surgery which you do, when you cut the posterior leaf of the broad ligament, ureter falls aside. And when this ureter falls aside, you will approach the uterine vasculature, which allows a huge distance between the uterine vasculature and that ureter. Okay. When you don't do this step, irrespective of what you are doing, you are encouraging that ureter has a higher risk of injury.
Do you do this routinely? The
Yeah,
posterior?
all the time.
Okay.
That's the only thing which we do. In fact, before we approach anything, when we cut the broad ligament, we just cut it down till the uterine vein. Everything is pushed aside in our routine hysterectomy.
Yeah. And in post-hysterectomy cases, I mean, what do you follow? Do we even need to do the ligation, like in post, like you said, the vault bleeders and all? So if it is like for a relook laparoscopy where the patient has been shifted post-hysterectomy, so if you have to do a ligation at the origin, I mean, what steps
Better
would
is to
you?
ligate internal iliac in that, because you don't really know if it is coming from just the uterine source or if it is coming from the vaginal source. Okay. So better is to ligate the anterior division of internal iliac. Just clip it. 10 millimeter vasoclip over the internal iliac. Whatever bleeding you have in the pelvis as a post-surgical hematoma, okay, everything will stop. No need to worry.
Okay, yeah. I think I'm done with the questions. If there is anything you want to add, you
No,
could.
I think what is important, I again want to reiterate, is that start doing this in benign cases first. When you start doing this in benign cases, doing it in laparoscopic difficult cases is going to become very easy for you. What typically happens is, yeah, in the current scheme of events, people end up uh, getting so confused about simple things that they end up attempting these steps only in the most difficult situations, understanding which causes even more problems because of altered anatomy. So, in order to boost your confidence, it is better that you do it in very simple cases first. Develop your confidence over this, and then attempt it whenever it is required.
Yeah. In endometriosis,
Okay?
is there any difference in the approach?
No, it's adherent. It's all going to be plastered if you have any form of parametrial endometriosis. So in that situation, again, your approach is the same. But what differs in endometriosis, I'll tell you. You would have already dissected the ureter by this stage. Okay. In endometriosis, you would have already dissected off the ureter. So then approaching the uterines becomes very, very easy, honestly.
Yeah. Okay. Okay.
Okay.
Yeah. Thank you so
Yeah.
much.
All the best.